Namaste and good afternoon. Greetings from all of us at Apollo Hospitals. This is Dr. Srinidhi Chidambaram, and I'm very happy to see you all again today. Apollo Hospitals has always been at the forefront in creating health-related awareness, as you have seen in all these Facebook Live sessions that we have been conducting regularly. So today, on the occasion of World Diabetes Day, I'm delighted to welcome you to a very special session, Latest Innovations in Diabetes Care. The International Diabetes Federation, the IDF, has recently mentioned that 537 million adults are now living with diabetes worldwide, and this has actually risen by over 16% over 2019. So it is certain that diabetes is one of the most serious and fastest growing global health emergencies of the 21st century. The IDF has also reported that of the 10.5% prevalence of diabetes mellitus in the world, there are almost half of these people who are undiagnosed. And by 2045, the alarming news is that 1 in 8 adults would be living with diabetes. And to make matters even worse, India is home to the second largest number of adults with diabetes worldwide, and that brings its own share of health, socioeconomic, and financial challenges. Diabetes, unfortunately, is not a condition that may show up many symptoms initially. Undiagnosed and uncontrolled diabetes can affect every aspect of your health, but the good news is that it can also be controlled, reversed, and prevented. So make sure that today you learn all about diabetes from our expert and also learn the major innovations and aspects of its treatment today so that you don't let diabetes or the complications of the disease take you by surprise. To discuss this very important and fascinating topic, I welcome Dr. Rabinder Nath Mehrotra, Senior Consultant, Department of Endocrinology and Diabetes, Apollo Hospitals, Jubilee Hills, Hyderabad. Dr. Mehrotra is a very senior consultant with over 20 years of experience as a diabetologist. He had completed his MD in General Medicine at the Motilal Nehru Medical College and the DNB in Endocrinology, Metabolism and Diabetes at the Sanjay Gandhi Postgraduate Institute of Medical Sciences. He's involved in clinical research in diabetes, osteoporosis and metabolic bone disease, has also received several prizes, including the first prize in the poster presentation in RSSDI, and has gained professional memberships in several associations, such as the Endocrine Society of India, Pediatric and Adolescent Endocrinology chapter of the IAP, is also a life member of the Research Society for the Study of Diabetes in India, life member of the Indian Society of Bone Mineral Research, and also a member of the Pediatric and Adolescent Endocrinology chapter of the IAP, and has also got several publications to his credit. So I can think of no one better to explain to you in detail today all about diabetes and what you can do to prevent it, and also about the latest innovations in diabetes care. Welcome, Dr. Mehrotra, and thank you so much for joining us today. So over to you.
Yeah, good afternoon, everybody. As we have seen, the main problem with the increasing number of the diabetes patients, and basically more in our part of the country. If you look at the causes that is causing this sharp increase in the number, the majority of the thing basically comes from our poor lifestyle. Our dietary habits have changed. We are taking more carbohydrates. We are taking more processed food, more saturated fats, and the exercise has become quite less. Everybody is under stress, and that basically is combined. Given that background of a genetic that we have from Southeast Asians, we are more prone to get diabetes at an early age. It's not only the diabetes which is frightening, it's the number of associated complications. If you look at practically around 25% of patients will have cardiovascular disease. And the Indian as such, we get it more earlier than what the Caucasian population will get. If you look at the number of patients with kidney disorders, we are getting more number of patients with kidney disorders. We have more number of patients with retinopathy. So it's not only the number of patients with diabetes, the number of patients with diabetes complication, which is going to be a great problem challenge for us in the future. Now, the strategy should be basically to minimize the number of new patients with diabetes. How that we can do? The challenge has to start, this thing has to start from the childhood.
Excuse me, doctor. You're not very audible. I'm not able to. There's a lot of break in your voice.
Okay.
Can you?
Yeah. If you look at the
Yeah, much better now. Thank you.
how can we prevent this number of increasing so sharply? So the intervention has to start from the childhood. If you have a healthy children, if you are not so obese, you will have basically grow on to a healthy adult. If they have the proper diet and exercise, they have lesser chance of getting diabetes. We cannot change our parents, we cannot change the genes, but we can change our lifestyle. That's becoming a very, very important part. Second thing is to pick up the patients earlier. As we have been told, practically half the patients of diabetes do not know that they have diabetes. By the time they are diagnosed to have diabetes, they already have some microvascular complications. So if you screen them regularly, if you pick them up early, you can put them on a kind of a lifestyle program or a diabetes management program, which will lead to a good control and less number of complications. Initially, we should say that we should start screening at the 35. Now that new recommendations are coming that we should start screening at 25, because we are seeing patients of the age of 20, 25 with diabetes coming in with very, very high sugar. And you put them on a good diet control and exercise and a small amount of medication, they do quite well. So that will really lead to the decreased burden of complications as we grow on into the future. Patients already have diabetes, they should learn to manage themselves better. Now we know that we have got pressures from the office, we have got the targets to meet, we have to go to the work and come back from the work. So we have to find time somewhere, at least half an hour a day to do regular exercise. We should be very careful what we are eating. While you are working on the table, we simply tend to eat finger foods. We tend to have some cold drinks. So that is very bad to look at. That we have to have some awareness. Okay, what I'm eating, is it correct for me or not? What my total calorie intake should be in a day, and how much I'm exercising? Or I'm checking my sugars on a daily basis, or maybe not daily, at least weekly once, or depending upon what kind of diabetes you have. Am I monitoring my sugars or not? Am I doing my A1Cs on the time? Have I checked my renal functions? Have I checked my eye sometime or not? So that basically kind of plan has to be there. See, we really cannot say that we're not looking for a short-term plan of 6 months or a 1 year. We're looking for a plan of 30, 35 years. We plan that you should have a good and healthy life in the future with less number of complications, so that your visits to the hospital should be quite less. That the aim should be. So that basically what is basically looking at the way we change our life, the lifestyle, that's going to play a very important role in the treatment of diabetes. We have the newer things coming up to help us to manage diabetes, but the feel that we have to do it ourselves has to come from the inside.
Yeah, it has to. Doctor, to begin at the beginning, what exactly should one look out for, and when should you be starting to go for your checkup? What are the earliest warning signs that you might be having diabetes or pre-diabetes? And also, is it also that sometimes there are no symptoms at all, and it is only revealed in the blood test and so on? So what should an individual really do?
See, there are two ways of looking at. One is the patient who are symptomatic, those who are losing weight, becoming weak, have genital infections, or have the kind of weight loss, or becoming very, very sick. So they definitely will have high sugar. So that symptoms will come quite late. Early warning signs could be sometimes the patient with obesity, feeling very tired and exhausted. That could be an early sign. Or in case we tend to get some skin infections which are not going to heal up, or some wounds which are not healing up, will be very important. So basically thing is, and second aspect is the patient, to screen patients who don't have any symptoms. If you look at the risk factor now, we may not do a blood test at that time. Now, if I know that my parents have diabetes, my brother have diabetes, and I'm age of 30 and above, I'm not doing regular exercise, my waist circumference is increasing, I have a poor lifestyle, I tend to have smoke or alcohol, then I should be checking it earlier. Do not wait for the symptoms to come, because symptoms come quite late. So I think everybody above 30 who has a family history or is obese should be checking it. ADA says above 35, fine, but that is the figure for their country. I would say our figure basically showing at 25 to 30, we should start checking at earlier age.
What is the whole phenomenon of pre-diabetes? So many people now have a metabolic syndrome and a pre-diabetes, which then evolves into diabetes. So how do you detect that, and how do you reverse that? Because at that stage, it still can be reversed.
Yeah, if you look at the pre-diabetes definition, basically it means a fasting sugar of more than 100, but less than 126, which is the threshold for diagnosing diabetes, or a post-meal or a post-glucose value of more than 140, but less than 200. That is the diagnosis. Or you can have an HbA1c where it is more than 5.7 but less than 6.4. So these three will give you the figure for the glycemic diagnosis of the prediabetes. But before that it comes, look at your risk factor. That's what I'm trying to say. Look at the obesity. That's the BMI is very important. Are you increasing weight? The children who are born with a lower birth weight but have gained weight rapidly in the childhood, so they have a weight trajectory which is going sharply up. Those are the factors we should be looking for. And prediabetes at a point is reversible. We know that the reversibility of diabetes being discussed quite well, but it all amounts to how much weight you can lose. If you can possibly lose around 10 to 15% of weight loss, definitely diabetes would come back to a great extent. I cannot promise that every patient who will have prediabetes will go back into the normal glucose tolerance, but at least your progression to diabetes will be retarded. So less number of patients will get diabetes. You will have a healthier life in the future. But the main criteria here is the weight loss. Now, weight loss basically comes from the dietary habits and exercise habits. So that has to change. India as a country is not a very great exerciser. We may do exercise 1 or 2 times in a day, in a week, and then forget for next 5 to 6 days. And the amount of exercise which is being done is not very great. So that we have to look at. So we have different Indian systems to help us. We have yoga, we have meditation, but then exercise also becomes very, very important part of that.
What about the diet, doctor? Like, you were saying that we have to, in India, of course, we have a tendency to have a lot of carbohydrate. Is it that one has to completely cut the carbohydrate for the prediabetes to get reversed and to lose weight? Because there are so many theories about it. Some people say that.
I would say go for a balanced diet. Don't go for an extreme. Don't go for a 0% calorie carb diet. I will say if you can cut down your carbs to 40 to 35, 30%, will be quite enough. Have adequate proteins, cut down the saturated fats, have healthy fats, unsaturated fats, omega-3, omega-6. That should be in a balanced ratio. Is very, very important. The carbs basically should be more complex carbs. They should have more fiber. Eat them slowly. Give the body the time to digest those carbs. That will be a very important part. The total calories, out of which carbs should come down, fat should come down, protein should remain adequate.
So now coming to also, you mentioned this about stress. So could you also, before we go on to the treatments, could you also discuss with us the role of stress in the evolution of diabetes and in the control of blood sugars?
See, exactly, nobody can quantify stress. I cannot say that you have got a stress level 1, 2, 3. Everybody has a different kind of stress. You look up any person in the hierarchy of the office, you have some kind of stress will be there. But then you have to learn to cope up with that. That means the exercise is very, very important, great stress buster. Yoga will definitely help you. Meditation will definitely help you. But maintaining a routine, kind of disciplined life will also help you out in that. Okay, I have to go for my regular exercise. I have to have my food on time. I have to have medicine on time. Okay, that's fine. So you have to add it to your in calculation to your daily plan. I have to go to the work. Fine. You have to go to the office and come back from the office. You have to drive. So you have to put into a kind of a place of disciplined lifestyle, which will help you in your coming on with the stress. The work pressure is there. It is there. Nobody can say that leave the job for a diabetes. No, you have to work on. The work has to go on, and then you have to control your diabetes also with that. If your relationship with your family or with your person in the office becoming very, very strained, then you may need to take a psychological opinion, take a counseling, or take the psychiatrist help to overcome the stress in that point of time.
But how does stress itself contribute to diabetes, doctor?
See, there are various ways of doing it. The most common, I would say, the presentation would be with the stress. Your lifestyle goes for a toss. You are not having time to exercise. Your eating habit becomes quite worse. You may miss your medicines. You may not check yourself. That's the most important point. Second thing is we have something like stress hormone, the cortisol, which is there, which will come up more in excess. They will also try to link to your obesity and your insulin resistance. They also play a part. So both the ways the stress can help you to destroy your diabetes control.
So now coming to the treatment of diabetes, so could you give us an overview about, what is the latest, what are the advancements in the treatment of both type 1 and type 2 diabetes today?
Yeah, so you see, the type 1 still remains the basic plan is the insulin, and depending upon the patient's affordability, you can prescribe them an insulin by syringes or by pen or by pumps. What is more important, they should be checking with it. It's not really going to help if you give them the costliest pen or the costliest insulin, but they're not checking enough. To look at the patient's profile and discuss with them the upfront the cost. Okay, this is the plan, and I'm going to cost you so much. What you're comfortable with. The child has diabetes because the diabetes is going to last on. It's not going to go away within 1 month or 2 months. It's going to persist. So what you are comfortable with. So that has to be there. In the insulin, we have got newer innovation. We have got newer insulin kind of, I would say, a kind of the, what do you call, the innovator insulin, which basically can be tailored to your lifestyle. Some insulin can be taken just before the meal. Some can be taken just after the meal. We have the basal insulin, which can be given at any time of the day. Those are the differences which are there. So depending upon what your kind of eating habits are, what kind of lifestyle are, the doctor will decide this is the best option of the insulin treatment for you. For the type 2, the basic, the three main plan was, one is the exercise, the basic plan, exercise and diet control will definitely there. Then we have the oral medications which are there. Now, the basic what differences come is now we look at the risk factors for your cardiovascular disease. It's not only the diabetes which you are interested in. We know that diabetes have more chance of getting a cardiovascular disease. They have more chance of MI, stroke. So we have to decrease that risk of stroke and MI while we treat diabetes together. So while treating diabetes, we look at the risk factors. Do somebody already has a stroke and MI? Then we have a different class of drug which has to be there on the board. Even if you're the sugar under control, like the drug like SGLT2 inhibitors or a GLP-1 receptor agonist, they have to be there on board if you have MI or a stroke, or you have got a multiple risk factors for the cardiovascular events. If you don't have those risk factors, we can start with the simple metformin. But now the basic plan was initially start with metformin, wait for it to fail, then add a second drug, then add a second drug. That has been changed now. We know that even if the sugar A1C is around baseline 7.5, start with a combination. The two drugs can act better. They act on two different parts, the pathways of diabetes, which make the control a little easier, and the control will last for a longer time. In the end, the result would be less number of complications.
So combined drug regimen is...
Yeah. From the very start, normally you see the people would say, sir, why giving me two drugs? Or why giving me a combination? Why not a single drug? Fine, I can give you a single drug. But then I have to go on to a higher dose of the single drug, which may cause more GI upsets or more loss of appetite, which may have the patient may stop medication at that time. So starting with a smaller dose of two medications, you have lesser number of side effects. Main thing, you have a better control, which lasts for a longer time.
One has also heard about the injectable non-insulin medications which have now come to treat diabetes. Could you tell us a little bit about that?
Yeah, the newer, as I said, the GLP-1 receptor agonists are coming in. Basically, we already had the injectable form. We had the liraglutide, we had the dulaglutide. They have been great drugs that have been shown to have a great effect on the cardiovascular risk progression. They don't cause hypoglycemia, they don't cause weight gain. But the problem there was injectable drug. And given the option, patients tend to little bit go away from the moment you say injectable drug, patients are a little taken back. Is my diabetes that serious? Should I take an injection? So now we have the oral form of semaglutide, which will be launched in India in the month of January, which has a similar efficacy of what the weekly injection would be, has a couple advantage of not causing the hypoglycemia, will cause weight loss and good control, and combines well with the other drugs that we are using for diabetes and has a good effect on the heart and kidneys that we're looking for. The other group of drugs is the SGLT2 inhibitors. They basically, normally our kidneys will reabsorb the glucose which has been filtered from the kidneys, and that tend to remain in the blood. So these drugs basically will block the glucose absorption. So glucose is passed from the urine. So there we lose the calories, we get better control, we have weight loss and no hypoglycemia. Have been shown to have a very good effect on the kidneys and the heart.
You were talking about the insulin pumps, Doctor. Could you explain to our viewers what exactly they are? And there is also these connected, you can also continuously monitor your glucose as well as administer insulin. Such devices have also now come. Could you give us some explanation about that?
The pump is what? Pump is basically I would say a computer, like a small computer in your hand, which has got an insulin reservoir, which can drive in through a small tube under the skin, will drive in the insulin into your body in a controlled manner. Now, the basic difference comes in now when we give the injection of a basal insulin in the skin by the pen or by the syringe. There, the insulin delivery happens for the whole day in a constant rate. We cannot change that control delivery between the, say, midnight, 12 o'clock to 3 o'clock, it should go less, and morning 4 to 8, it should go more. I cannot do that. So in that, sometimes what happens is trying to control the fasting sugars, we get hypo in the midnight. Or if trying to control the midnight hypos, we get the fasting high sugar. So the pump basically can be controlled to give you a basal rate which can be different in nature. I can order the pump, okay, between 12 to 3, give only say 0.5 unit per hour. Between say 4 to 8, it can give you 0.8 per hour. So when I'm going to play, it should decrease the insulin being pumped into the body. So I can tailor make the insulin delivery to my body regarding my lifestyle or my requirement. So that basically decreases the risk of hypoglycemias, decreases the number of fluctuations, give me the better control, which could be very helpful for the pregnancy or for the future complication. Kids love it at that time because they don't have to prove, they can go and play and eat a little bit extra when they want to eat. That becomes a great advantage. So I can control the delivery of insulin according to my requirement. In the insulin given by the skin, once it is given, it will act for the duration, there will be 6 hours or 8 hours or 12 hours or 24 hours, and that action will be there. I cannot stop the delivery from that depot once it is injected to the system. So now, coming to the question of what kind of pumps we have. The basic pump basically have is it pumps the short-acting insulin into your system in the skin. The absorption is quite better than what we get absorption from the injection. It is a more predictable response. So that basically means if I've given the 5-unit bolus today and I'm giving the 5-unit bolus tomorrow, I may expect the same response. But same may not be true for the injection given by the syringes or by the pen. If I give the one injection today and tomorrow, the effect may not be same. So what we see the fluctuating sugars. Some patient tells me today my fasting was 140. Yesterday it was say 100. Today is around 160. So that variation comes in the absorption of insulin. The patient is taking the same kind of food, same dose of insulin, but the effect is seen as different. But the pump, because the insulin is the short-acting insulin, the absorption is quite better with that. So we get a more predictable response. Moreover, if you look at the pump, basically as I was saying, the pump will have only where you check your sugars, you look at your carb intake, and then decide how much I'm going to eat. So check the sugars and then see, okay, I'm going to eat say 25 grams of carbohydrate. My insulin carb ratio is going to be 2. So I will be taking say 5 to 6 units of insulin. That is the normal way the pump works. Second thing is, if you connect it to a CGMS pump. Now, CGMS basically is a kind of a sensor which is put into the interstitial compartment of the skin, where it continuously senses the glucose. We have different kind of the monitoring devices. So they could be real time or they could be intermittent scanning time. So there it can communicate to your pump. Now, if the communication is happening between the pump and the sensor, and the pump has an algorithm, it can sense, okay, my sugar is going up. I should be increasing my insulin supply. That is called the closed loop. Other is called the hybrid pump. Now, in case what happens when the sugar starts to fall, my sensor has shown to the pump, okay, the sugars are falling, the pump will shut down. Okay, my sugar has reached to 70, pump will not give the insulin on the subcutaneous system, the pump will stop. But when the sugar starts to rise again, above threshold value of 90-100, the pump will start pumping the insulin again. That is the simplest kind of what I call the initial pump. Second, the sensor can tell you the rate of fall. Suppose my sugar was 140, it is sharply falling to 100 to 90. The sensor can send that signal to the pump. The pump will send the rate of fall is going to be excessive. It can cut down the insulin supply or shut down the pump at that time so that you will not go into hypo. Or if you go into hypo, you stay into the hypo a very small amount of time. And when the sugar starts to rise again, the pump will start pumping the insulin again. So that is a great advantage. But remember that the sensor has to be on for that. Without the sensor, you have to check your own sugars. The problem what we face in India is the cost of the sensor and the cost of the pump. It's not going to be, if you put a pump and not checking the sugars, it's not automatic machine by itself which can control the sugar. So both have to be there. You have to check and use the pump. If you have the affordability, you can use the sensor. Sensor life basically will be for maybe say 5 days or 6 days or 7 days maximum, depending upon what kind of sensor you are using. There are other kind of monitors are there, the flash monitors. They record the reading, but they cannot communicate with the pump. The CGMS of the sensor and the pump of the same variety or the same company, they can communicate to each other and give the signal. So that basically gives you a better control, lesser number of hypos. That is what is important.
What are smart insulin pens, doctor? Are they any different from the regular insulin pen?
Yeah, normally if you look at the pump, the pen which we have the pen device which has a cartridge, has the needle, has a dial device. We dial the dose and inject. After dialing injecting the dose, the dial again comes back to 0. Now the smart pen basically are only meant for these. They have been recently approved by FDA, not available in India as of now. It's called the InPen, and they come with an app with that. They work quite well. They basically can keep a record of what dose you have injected. it can be linked to your CGMS and can tell you what the sugar values are. And then it can also help you with the wizard to what dose you should be taking. If you know about your insulin carb ratio, you know what your sugar values are, and you know what you're going to eat, then the pump pen can help you with the app, the Bluetooth app, to tell you how much dose you should be taking it. Basically, as of now, we have this kind of pen for the short-acting insulin, like Lispro and the Aspart, the glutamine. Is not there for the basal. I think it will be coming shortly for that. But it's basically a kind of device that help you to track your sugars quite well.
Do you also, we have a lot of smartphone apps now, so which people use that in tracking their, not only their diets, but also maybe blood sugar levels or medications. So what do you think about these, and in what circumstances do you think they're helpful for diabetic patients?
The apps are basically a great help, I would tell you. If you look at the data are very, very clear now. The patients who can use the app or have got the access to technology, they can get a better control because they have less number of visits to the hospital. They can be more compliant with their diet and exercise and your what you call the medication. The app can help you to track all the things. It can help. App can track your medication, and then if you can see if you have taken the medication on time or not, what food you have been taking. It can track if you are entering the data. It can track your carb intake. It can track your protein intake. It can track your weight in the BMI. It can tell you, okay, your weight has been increasing in the last 1 month. We have been consuming more calories. You have to be more careful. Then it can help you to track your insulin dosages. Okay, your sugar has been this much and you've been taking this dose. So whether you've been correctly or not, whether you need to adjust the dose or not, it can help you in that. And basically it gives you a reminder of the medication. Suppose the patient is in office, if he forgets to take his tablet before the meal, he takes it after the meal, the effect might be different. So apps can basically help you in any way. There are all the ways which can be there to track your sugar, to track your medication, and track your complications.
Now we have been getting quite a few questions from our viewers. So I will just now read them out for you, doctor, then you could answer them. So the first question is, how can I lower my blood glucose level quickly?
How can I lower my blood glucose value
quickly?
Now, basically, quickly depends upon what kind of need is there. If suppose somebody is planned for a surgery, somebody has infection or pregnancy, we will definitely start insulin with the diet control and exercise, but may not be safe with the surgical patient. But that and check the sugar more frequently can help you to get down sugar. Suppose a patient has come to the sugar of 350, 400, and is a planned for a surgery or day after tomorrow. He's got a food infection. So there, the insulin works the best. So depending upon the situation, where you are and what is the need for the quick lowering, we'll go for it. Suppose they come with a sugar of say 250, 300, you have got no symptoms, picked up on routine investigation, routine evaluation. I would say give yourself time. Don't rush into it. And then maybe a couple of weeks, you can cut down the line with the proper medication and diet. It will definitely help. We have seen in young patients coming with very, very high sugars, but the moment they start cut down the diet control, go on to cut down the carbs in the diet, they cut down the cold drinks and the fruit juices, sugar start to fall dramatically. So basic principle remains the same, but depending on the background of the patient, we will decide how quickly the lowering should be there and what medication should be used. But overall the rule, if you want a very fast recovery of the lowering of the sugar, insulin works the best.
The next question is about diabetes in children. They are on the rise. So is there any specific reason or cause?
See, basically, if you look at the diabetes in children, if you're looking at the, say, above the teenage, I would say that was more of like type 2 coming earlier or coming from the family history of diabetes, and obesity could be there. There's some kind of genetic diabetes could also be there in that group. But practically what we see between, say, 1 year of age or 2 years of age to the age of, say, teenage, that is particularly type 1. That is more common in the Caucasian. We have been seeing more number of patients because some patients have been treated earlier in the periphery. What should happen was the patient would go to a primary center and a DKA would not survive and would not be able to come into the city. But now, with a better primary care in the periphery, patients are getting better, they're getting treated, then they come back to us. But the diabetes, that will be type 1. They will require insulin for lifelong. Then we have a diabetes in the newborn or in the before the age of 1 year, which could be a part of genetic, that is called the monogenic diabetes, which if picked up, normally we put them on insulin, but if we do a genetic test for them, and then we prove that it can be that these patients can go on to tablets, they can be put on tablets. So we have the whole variety, but predominantly if the child is getting diabetes, we like to treat them a type 1 first, unless we prove them that they're not type 1.
What is the, I think the question is more about the type 2 and the lifestyle causes of diabetes occurring in younger and younger age groups.
Yeah, but see,
So that
as I said,
is
you cannot change
usually,
your parents. Parents are there. Parents, if the parents have diabetes, they have diabetes. You cannot change them. But the lifestyle is very important. If you look at the children obesity now, if you look at the figures published a couple of days back in the Times of India, the figures are alarming. We are sitting on an endemic, the epidemic of obesity in children, which will drive the epidemic of diabetes tomorrow. If we want to have a healthy adult, we have to have healthy children, and screen time has to be cut down. If you look at the past 2 years, the children's screen time has increased dramatically. They've been sitting indoors, and the finger foods have gone up. The supply of the cold drinks and the chips or the pizzas and the high calorie food is increasing. So the more the weight you have, the more chance of getting a diabetes you'll have. So the lifestyle is a basic problem there.
so physical activity and
yes,
a nutritious diet.
Push them out. Don't let the children stay in the house after they come back from the school. Let them go out and play. That is more important.
If it is sugar-free, I can eat as much as I want, right?
Pardon? Sugar-free? No, see,
Person asking if it is sugar-free, I can eat as much as I want. No. Is it not?
Look at the calorie content on that. Whatever the food you're going to eat, be conscious how many calories you contain. If you look at sometimes the sugar-free cookies, they contain more fats and they contain more calories. Okay, you have cut down 5 grams of sugar, you have cut down 20 kilocalories of the sugar glucose, but you have taken more calories in the fat. 1 gram of fat has got 9 calories. So look at the calorie intake of the cookies or the diet you're going to take, and then decide whether it's healthy for you or not. Some of these sugar-free ice creams or sugar-free cookies have more calories than what you take for your lunch. Yeah. So be very careful. Look at the package and so your government has made a rule that every package what you're going to eat should have the list of calories on that. So read that calories and then decide.
Why does it matter if my blood sugar is 120 or 200?
See, if you look at the problem in diabetes, it's not only the sugar values. Our body's vessels have not been designed to withstand so much of glucose. So the arteries wall get thickened and they get closed, and that leads to ischemia of the organs. If they happen in the eyes, we get pulmonary retinopathy, we become blind. If they happen in the brain vessels, we get stroke. If they happen in the heart vessels, we get the MI. If they happen in the leg vessels, then we get the PVD or the peripheral vascular disease or the leg ulcers. If they happen in the nerves, we get the nerve problem. If they happen in the kidney, we get the nephrology. The basic problem is not only the sugar value, but the sugar value crosses the threshold. It damages your vessels, and that damages your further organ, which lead to end organ complications.
What is the best predictor of type 2 diabetes?
Weight and exercise. How much is your weight? How much is your BMI? And how much exercise you're doing? These two factors play a very, very important role in your risk of diabetes.
My weight is decreasing day by day, and I'm having a burning sensation in the urinary tract and pain in the upper right abdomen. My blood sugar level is 106. What should I do?
If you're losing weight and you're having the burning pain basically in the leg, means that you got an onset of diabetic neuropathy is coming in. So you have to look for the cause of neuropathy and treat them. It could be an uncontrolled diabetes. Your sugar today may be 106, but what is your daytime sugar that you should look at? Look at your HbA1c, look at your post-meal controls. If that is not under control, you will still get the diabetes complication. Don't look only at one part of the day. Look at throughout the whole day. That becomes very important here. The burning and the pain in the stomach could be a part of diabetic autonomic neuropathy. Gastroenterology can be there, or it can be a thoracoabdominal neuropathy, or it can be a simple gastritis also. So consult your doctor. They can help you to see what the causes are. And sometimes it happens that while trying to control the sugars, we tend to avoid the insulin. We tell the doctors, okay, don't give me insulin, give me more number of tablets. If I'm remaining uncontrolled and I'm eating the less than what I should be eating, I'll be losing weight.
Why do the diabetics have thick toenails?
Pardon?
I don't know. This person is asking whether the people with diabetes have thick toenails. Do they?
Okay. So basically, they're going to be part of neuropathy. The neuropathy will lead to more and more of trauma. Suppose I get hurt. I know that my feet has got hurt. I will take protective care of that. Diabetic patients, they have neuropathy. They have small trauma happening throughout the whole day, and which may damage my nails, and which I will not come to know. Sometimes it could be a fungal infection of the nails. So those two things are there. Neuropathy and the fungal infection are the most important part.
So it's important for diabetics to go for regular
It's
foot
very, very
care.
important. And in case when you go to a doctor, the doctor will examine your foot at least once in 3 to 4 months to see if any complication is coming there or not. In case you see a problem, we do take a help of podiatrists. We have specialized surgeons who can help you to take care of your feet. But basic care is to examine your feet on a daily basis when you go to bed. Look for any ulceration, look for any injury signs, look for any signs of redness or erythema. Look for skin thickening. The skin thickening, when it breaks down to an ulcer leading to foot problems.
Is UDAPA a good medication?
UDAPA is I think dapagliflozin. As I said, these glyphosate has been shown to have a good effect on the kidneys and the heart. They are good medicines to use, but they are basically, thing to remember, they are medication. They can have some side effect. So discuss with the doctor in case you have any urine infection or genital infection that has to be taken care of. Otherwise, they are very good medicine. Overall, if you look at, these are very safe and very good effective medicines to be used for diabetes.
Why do diabetics need oral medications to manage the condition?
See, the oral medication, if you look at, works in different ways. Now, it may be a tablet, but a tablet can be of different kinds. One we have is the combination is metformin. Metformin basically makes the liver make less glucose in the night time, so our fasting sugars come down. It helps to increase the insulin action in the periphery to make more insulin sensitization. That is very important, great advantage of metformin. Metformin is the oral drug. We don't get injectable form. Then we have the drugs like the DP4 inhibitors, like sitagliptin or linagliptin or teneligliptin. These gliptin basically helps to the body, the pancreas, to make more insulin when the sugars go up. They have an advantage that they will not act in case the sugars are low. Suppose the sugars are 70 and you have taken this medicine. So they will not let the sugars go down below that. They will only act when the sugars are above a threshold. So they control the sugars, but they don't cause hypoglycemia. Then come the drugs like what you're saying, the dapagliflozin or empagliflozin or tetragliflozin. They work very different. They basically block the absorption of glucose from the kidneys. They basically help to lose glucose from the urine, and that will decrease the blood sugar, decreases the weight, and help the blood pressure, and has a good effect on the heart and kidneys. Then we have the drugs like sulfonylureas, like glyclazide or glimepiride. They've been very, very used for a long, long time. They're very great medicines, very simple, safe, and cheap medicines, but they have a problem. They can cause low sugars and weight gain because they'll keep on acting on the body even when the sugars are low. So that you have to be very careful about. These are great medication, but you should be using them carefully. We need to bring down the blood sugars. Diet control and exercise may not be all sufficient to do it. Our body is making less amount of insulin, or that insulin is not being made in the proper quantity or not being proper effective. So we have to use drugs which can make the insulin work better in the periphery, or can increase the insulin supply, or can make the insulin work better in the periphery. That's why we need medication in diabetes.
Hello, doctor. My son is 6 years old. His weight is around 41 kg. How can we reduce the weight?
The basic plan is the same. If he's not diabetic, I would say definitely look at how much he's playing in a day, how much time he's spending in his mobile phone, laptop, or TV time. Cut that screen time. Let him go and play physical game and look what he's eating. Give him more vegetables. Give him more home cooked food, rather than the processed food from the cafeteria or the outside of the hotel. Cut that out. The weight will definitely. We're not looking for a weight loss in children. What we say is if the weight stabilizes as the height increases, the BMI will stabilize. We don't want the height weight to come down from 40 to 35. No, we don't want that in children. They're growing children. They want calories. They want proteins. So they let them grow, but let the weight not increase as exponentially as it's been increasing in the past.
There is a certain theory that, when there is a high intake of fat, like a ketogenic diet or a very low carb and high fat diet helps in quickly reversing the diabetes. Is that based on any scientific fact, doctor? Or is it okay to take such a large amount of saturated fat?
It's a very commonly discussed question now. Basically, if you look at the ketogenic diet, they have only carbs of 1 or 2%. The rest, practically more than 80% is only fats. So that basically, it has a different effect on the metabolism. So the patient will tend to lose weight, but your lipids will go for a toss. Your cholesterol will go for very, very high. Definitely, you will lose weight. Your sugar recommend medication will come because you're not taking any carbohydrates. The insulin should be better. So this should have a good effect for maybe say 6 to 8 weeks or 2 months. We have no data to suggest that or show that this is going to be safe for the long-term point of view. That way, if you look at the balanced diet, It has the same same kind of principles: less carbs, less fats, and adequate proteins, which can continue for a longer time, have been shown to have a better safety effect on these kind of for the patient of diabetes. That's important. Moreover, the patient who are already on insulin, I would suggest they should not go for ketogenic diet. Somebody is obese on metformin, definitely can try it for a short term, but under the guidance of your doctor. Look at the lipid values before and after, and then decide. So I would not say that every patient should go on a ketogenic diet. Non-diabetic patient can try it for a weight loss. It will help them for a short duration. But I cannot see anybody taking that kind of diet for 6 months or 1 year continuously. It's not possible to do that.
Absolutely.
So having more balanced approach is much better.
So this brings us to the end of our session. So I hope you enjoyed it, dear viewers, and thank you so much, Dr. Mehrotra, for taking time off to explain all the concepts of not only the treatments, but also about prevention of diabetes and early detection. So diabetes, as we see, can be managed. Pre-diabetes can be stopped if caught early and treated with relatively simple lifestyle measures like losing weight, cutting back on daily calories, and definitely staying physically active. So don't take a chance, get yourself screened for diabetes, pre-diabetes, manage the disease well, and make sure that you control and not let it cause serious complications. Thank you, viewers, and please subscribe to our YouTube channel to get the latest information on trending healthcare topics. If you have more queries, you can always post comments on our Facebook page, or you can also contact us by posting your messages on the inbox. And at any time, we're always there to help you out. So don't hesitate to reach out to us. Meanwhile, take care, be safe, and see you soon. Thank you and namaste.
Thank you. Good afternoon. Have a good, nice evening.